Evet, günaydın.
Okay, good morning. First of all, welcome to our satellite session. I think the room is filling up, but let's start without further ado because we need to use the time effectively. First of all, I would like to thank you for joining us. My name is Ali Safet Gönül from Ege University. I'm a psychiatrist. Some of you might know that. Today we have gathered here for a satellite symposium organized by JANSSEN. We're going to talk about esketamine. I would like to thank JANSSEN for organizing this symposium and for bringing a brand new medication into Turkey, because recently we do not see brand new drugs coming into our country. We have esketamine and maybe few others. Of course, this affects our daily practice, and sometimes we have problems with the current medications that we have. So these new drugs are very important. We thought about who would be the best person to talk about this, and the first name which popped up in my mind was Philip Gorwood, because I've been listening to him in different meetings, and he's a real expert in this area. And as a clinician, he's going to lead us the way, I think. So I believe you're going to find this very fruitful and beneficial. Professor Philip Gorwood is has been publishing a lot in international publications, especially on MDD, and he is one of the foremost French psychiatrists who has been referred to between 2020 and 2023. He was the chairman of the European Psychiatric Association, and right now he's working in Saint Anne Hospital as the head of neuropsychiatry. And as you will see, the data he is going to present will be produced or researched by his own clinic. And of course, you can ask questions at the end of the presentation, or you can talk to him. Yes, Professor Gorwood, the floor is yours.
Please welcome Professor Gorwood.
Thank you, Professor Gönül, for these kind words. I'm not sure I capture all the points, but it's really very kind of you. Thank you so much for being there, because in a hotel like that, we have so many swimming pools. I think it's a challenge that you are here today, so congratulations for you. It's nice that we're doing that also in mid-August. Have you seen the weather and the temperature of the sea? It's just incredible now. So let's go to the point. I would like to share some experience now with a new product. When we try a new product, we are always a bit scared. What is it? Who are the patients for which I will try this new product? Will I feel sufficiently comfortable knowing all the side effects? What is the effect I should expect? For that, I guess that the best point is to exchange our experience between clinicians, and that's the point today, where I would like to share the experience we have, because in my own hospital, we have a lot of patients being treated with esketamine. I have a crazy doctor. He said, "Have you go, Philip, you can prescribe as many as you can." So we prescribe more than 100 patients with esketamine, and it's great that we see now and feel a little bit more about what is it exactly and for which patient should they use it. So these are my conflicts of interest, most important points that have been invented by JANSSEN today, so thank you so much for their nice invitation. So the point is that the indication is a new one. It's not so many treatments are being indicated for treatment-resistant depression, TRD. The point is there is a huge need. You all know that depressive disorder is going to be the highest burden on society, and so we have to find cues in order to reduce this burden, reduce the incidence of the disorder, and save money. And when we talk about the price of treatments, in psychiatry, we always say, you know, the esketamine is so expensive. It is terribly expensive. But have a look about cancer and cardiological disorders. Their cost is much higher than that. So psychiatry usually is very cheap. We shouldn't be cheap. It's a huge specialty with a huge burden, so it's not a surprise. Why should we treat our patients as quickly as possible? I would like to give you two information for that, which are only, you know, indirect cues. They're not complete, clear evidence. But they really push for this idea that we should make huge, intensive efforts as soon as possible and as long as possible, not only for the immediate prognosis, but for the lifetime, long-term consequences. On the left, you see that this is the TMT for those who know the type of test. It's a very simple one. You need to go from one, there's a large panel with numbers, letters and numbers. You have to find one, and then you look for number 2, then you cross a line between 1 and 2, and then you get to number 3 up to 25. It usually takes 30 seconds, very easy. Not a surprise, when you are depressed, you see that on the left, first episodes, blue square, patients are slower. They have difficulties. They have psychomotor retardation. Not a surprise, it's a core symptom of depression. But as soon as they have treatment response, on the left, the red one, much better, closer to 30 seconds. And when they're completely remitted, the green bar is then 30 seconds. Go back to normal. This is true for episode 1, episode 2, episode 3. But if you look afterwards, your capacity to go back to baseline are being damaged, probably because of the time being depressed in your life. And even though you get much better after the treatment, you do not get back to baseline values. These are stigmate of past depressive episodes. So when you avoid, for your patient, episode number 4, you are saving their brain, at least for psychomotor retardation. The right part is on delayed memory task. It's a part of the test on the Wechsler test, which tests about how many concepts and words do you remember. I'll tell you a very boring stories, my neighbor getting to the bakery, being late, and then asking for some money and so on. A lot of tiny, boring details. Then the patient fills the questionnaire, and 2 minutes afterwards we say, how many details are you able to remember about the past history that I just told? And as you can see there, your narrative delayed memory goes down and down each time you had a depressive episode. So once again, when you prevent a new episode, you are also saving the memory skills of your patients. All of it, these are the slides I show to my patients. I love to share material. You know, we are in France very keen with the shared decision process, where we do not explain what they should do, but we give the evidence that we know, because we are experts, and we say, now, what's your idea? How many of your patients say, no, I want to stop this treatment. Now I'm okay. Okay, but then see what it is if you have a new episode. Oh, what would be your conclusion? How do you understand the slide? And I would support and strongly push you to do that. Show slides to your patients. Use their brain, not your authority. Doing that, you will have much better treatment results. So we push for this kind of information because of that, protecting the brains of our patients. Treat early, because less time being depressed, better saving. Get better. No more remaining symptoms. Remaining symptoms are the cue. Remaining symptoms tell you the patient is going to have a relapse. If you listen to these remaining symptoms as an alarming message, a red flag, you will improve their long-term functionality. And then for a longer time when you have many resistance and episodes. So for treatment-resistant depressions, they are the worst, most difficult. I prescribe, I do it well, I find a very appropriate treatment, no more response. And then I change to another one, which is really good. I have a very good experience with the treatment, no more result. Oh my God, this patient is difficult. No, The patient is not difficult. The depressive episode is difficult. So that's the concept of treatment-resistant depression, not depressive patients, depressive episodes. So how are we going to make the definition of that? There is this new manuscript in the world psychiatry where we were 20 to look for core information that could describe who are those TRD, treatment-resistant depression. The first one, which is shared by the majority of consensus and informations, is about the number of treatments that are required. Quite interestingly, for some of these guidelines, they said just one failure is enough. It is a resistance because there was no response. It makes sense. But in clinical practice, that would describe a huge amount of patients. So usually the consensus is more about 2 failures. The required duration of failed treatment. If you prescribe a treatment for 2 days, you will have no treatment response. You will all agree. If you wait for 6 months in order to be sure you have a treatment, yes, of course, you will be very sensitive, but you will lose a lot of time. And now the consensus is more and more about 4 weeks, a full month. And then the agreement gets lower with the failure of ACT. For me, it's the worst point, and we push to avoid this one. My experience, we do a lot of ECT in my hospital because we have a huge amount. My hospital is located within Paris. We are the only psychiatric hospital within Paris. So we do the vast majority of ECT for the whole town of city of Paris. So that's a huge amount of them. And for those patients with this, usually they have 4, 5, or 6 failures before ECT. So if you prescribe esketamine after ECT, well, these patients are usually completely chronic, severe, and resistant, and you will have poor response. Failure of augmentation, that's a very interesting idea. The most important point is that TRD means 2 failures. But if you propose 2 SSRIs, probably you miss the point because you use the same mechanism of action. So it would be good to have 2 different molecules in 2 different types of mechanisms. And if you are more comfortable only with SSRI, then prescribe another treatment, such as, for example, an antipsychotic. And then getting to the definition of TRD would make you possible to prescribe esketamine. Baseline severity included. It's really interesting because usually TRD have higher severity level. But is it a request or only an observation that is to be discussed? And the duration of the current episode. Everywhere in all the literature, the longer is the episode, the decreased chances we have to have treatment response. So then, as soon as you have this definition of TRD, it's nice that you have the idea of what can I prescribe, how can I help these patients, but never forget, and that's a point I would like to mention here, that it is not only a question of prescription. Why do you have TRD? Somatic comorbidity, age, alcohol, substance abuse. We have a lot of alcohol drinking, as you know, in France with our good wines. And so in this case, you have poor treatment response because patients do have alcohol use disorder. So you miss the point if you just prescribe treatments because you have then an explanation. And these are the different ones that have to be monitored systematically before getting to the next step. There's an alternative to the TRD concept, the treatment-resistant depression, which is difficult to treat. And I know that you have a Hamish McAllister this afternoon as a video presentation. And we made also this consensus about maybe, it's important to allow to make this diagnosis the first day you see your treatment. Because we all have these patients that have melancholic features with psychotic symptoms, extreme psychomotor retardation, and different anxious comorbid disorders. These patients are nightmare because they are going to be very difficult to treat. And we know that immediately. So with this, we can propose to adapt our strategy, taking into account all those aspects. And the other point that we insist on with this paper was to say that please have a go to the different steps. If you have a severe resistant patients or difficult to treat, have a look about comorbidity, especially anxiety. Anxiety is the most informative non-response predictive marker. Have a look about core symptoms, because if you have insomnia or anxiety, they are exactly the opposite. So we need to look at, hypersomnia or anxiety. And then the treatment we're going to fetch will depend on this scheme of symptoms and look about the different factors that are helped. So that was just to mention that once again, it's not only a question of prescription, but also of how we manage that. Why TRD is so important? Because these patients are the most severe. They are also having more suicidal ideas. We know that suicidal ideas predict suicidal attempts, which predict suicide mortality. The quality of life is decreased. The functioning at the professional level is being damaged. You have more hospitalization, which means also higher cost. Getting to the emergency rooms is more frequently observed. Higher comorbidities, especially when you have 2, 3, or 4 comorbidities, and higher global cost. So there's no doubt that we should do an effort specifically on these patients. What is it in real life? This is one center that takes care of patients with TRD, and it was a relatively large sample, more than 400 patients. And when they get to this specific TRD department, usually they failed, for half of them, to 3 or more of trials. So they are being depressed for a very long time. It's around 14 years of unipolar disorder. 5% have failed on at least 5 or even 6, and half of them were unemployed or on sick leave. So there is no doubt that it's a very damageful disorder. Another very important point is that, when we look about the efficacy of the treatments that are being prescribed for TRD, we look at the trials that are being supported for the EMEA or the FDA for the indications. But we should stick to what is observed in real life. That's the efficacy we have in real life in a TRD center. Patients arrive being depressed, and the level of those gaining remission after a year is only 3%, a very small number. Response, but no remittance, 2%. And no response, you just decrease it by 4%. So it really shows that it is difficult to treat depressive disorder, not a surprise. We made another consensus about the management of TRD. That's an issue of the World Psychiatry that was published this month. And we said that we have a lot of different opportunities. Your patients have no proper response. It's the second time, so then you have a patient with TRD. What can I do? Well, the first point is maybe you can continue, because we do have late responders. They do not have the response usually in the 4 weeks, but later on. And that's the case especially for the old patients. It's the case also when you have a lot of psychomotor retardation. And for those patients, usually you need to be a little bit more awaiting attitude. Not so frequent, but if you had that before in a previous episodes, that's a very good indicator that we should wait. This is one of the less frequently used technique because it can be also very damageful. The second one is switch. This is something we do very easily. We switch from one treatment to another one. We try to change the targets and especially fetch a treatment that tackles the symptoms that are very important for the patient. I feel so much anxiety. Please, doctor, do something for me. If you give an antidepressant treatment, which also reduces anxiety, the patient says, wow, I have a relief, then it works. We all know it's not the case. It's a side effect with a little bit of sedation, but then we reduce anxiety. But for the patient, it's a good sign because they feel better. Or you can combine, and that's the case also for, especially if you want to have a little response, insufficient, but an improvement with your past treatment. You don't want to stop it. The patient hates that. They took it for a week, for 4 weeks. They feel a little bit better, but it's not enough. And they say, well, yeah, forget about that. We're going to change and completely start a new one. Wow, but why? Why did we lose a month? And if you have some improvement, keep it. And then you combine with another antidepressant treatment, which is, of course, compatible. And then you might build on what you previously done. For patients, it's very difficult to accept losing a month of treatment with some partial effect. Esketamine now is an alternative. Second-generation antipsychotics are being prescribed for some of them. And I would say that it is especially interesting in those with suboptimal response. That was, in fact, the indication initially, for which especially you have remaining anxiety for these patients, you might have a benefit there. ECT is a kind of gold standard. RTMS, My experience is that it is very good, even in TRD, only if you have the setting, the good material, trained staff, and an RMI, because location of the probes are very important. So it is probably restricted to very specific departments for which it is very useful. For the other ones, and especially in mine, we don't use it so much because we don't have fantastic results. VAG stimulation is a new hope. It's a little bit traumatic, not as deep brain stimulation, but it's nevertheless a little bit of surgery. But it is very good for very chronic disorder, much more than TRD. I would put chronicity probably the better target. And don't forget about psychotherapies at each step, initially, afterwards, and even for remaining symptoms. So that is what we said we could do. What are we doing? None of it. None of it. We are very bad at prescribing for TRD. This is a whole nation study in Norway, in Norway where whatever you do, it's in the computer. Big Brother is watching you. You prescribe it or you take it. You go to your GP, you go to the pharmacist taking your drug. All of it is in the computer. They know everything. Fantastic for research. I'm not sure I would love it for me, but anyway. So for this case, what are we doing for TRD? These patients were treated with a negative response for 2 different treatments. What do they have? Monotherapy. We continue switching. When we did that for 3 treatments, third line, you get to the orange in the middle, we get once again priority switching. 5th line, which means 5 different we continue switching one to the other one. That doesn't make sense. Mechanism of actions are 3 or 4, but not 5. And usually, in fact, they're the same family of molecules. So because combining means that probably more side effects or treatments we don't know, ECT is too difficult and dangerous and people don't like it. But then the point is we have very poor results because we continue switching on and on. So what is this new alternative? So just to be completely clear about the indication up to now, it is major depressive disorder, which failed to 2 treatments that were adequately prescribed, which I would say is at the correct dosage and at least for 4 weeks. Doing that, you will have no problem depicting who are those patients in your own clients. So what's the mechanism of action of this molecule? It's a very simple one, and it's a completely new one because we didn't look at NMDA receptors before. The point is, it is blockading these aspartate and methyl D-aspartate receptors. These receptors are located everywhere in the brain, but the most important concentration is on the GABA neurons that moderate the activity of the main transmitter, which is glutamate. So if you inhibit the modulator, you facilitate a glutamate release. As you release glutamate, it's a storm in the brain, and the brain has to adapt. And as you know, neurotrophic factors, it's their job. And so the BDNF is getting higher because it's the only way to adapt to this huge increase of connection between different synapses. Doing so, you are increasing connections. This is the scheme of the molecule. But I love the proper study that was published in Science, which is really convincing about its mechanism of action. So in this slide, they've been looking at rats. I know it's not patients, but opening the brain and looking at synapses is a little bit difficult in human brain living. For rats, might be more easy. They looked at cortisol as the model of depression. That means they give cortisol, and they saw that the level of mobility of the rats get decreased. They say very quiet, looking like being depressed. It's a model, but we know it's relatively predictive of antidepressant resistance, so it's really making sense. If you look at then the spine formation, how much your brain is creating new axons, new synapses, that this sprouting mechanism is being abolished when you have huge cortisol. And when you have this high cortisol, no more sprouting, no more new connection between brain areas. And this is highly correlated with this immobility. So it's a good model of depression for assessing the impact of a molecule. And if you look at this part, because these were in vivo, what does esketamine, 1 day after this model being organized, after 3 weeks, 1 day afterwards, you see all those new synapses ready to connect to other ones in order to reconnect the brain. So that is really impressive. For once we have a model where depressive symptoms are being correlated with the synaptic connections, and these synaptic connections are spreading around just a single day after ketamine and esketamine. What is interesting is that it is probably the same with SSRI, SNRI, but not 1 day, 2 weeks, because BDNF needs more time to get released with SSRIs and SNRI. So in order to understand, because the treatment is a bit expensive, I think you would agree on that, we wanted to know who are the ones we're going to prescribe this treatment, because we want to tackle especially those for which we're going to have a good response. So for that, we've been using our patients. We had 50 patients at the time. Now we have more than 100. And we had another department in the same hospital, which is a completely different one, where they also had some experience. So we merged our two samples, only TRD, everyone having MADRS systematically, and we followed our patients. We used the latent class analysis. I'm not sure you're very comfortable with that because I didn't know it before, to be completely honest. It's a relatively strange. I don't know if you know the ACP, the principal component analysis. You know, you look at all the dots and you see how much are being connected into specific clouds of dots that are really close. These are for, information. You see at clusters of symptoms that resemble in the population. And this time, that's exactly the technique we used, but not for the direct connection of symptoms between themselves, but at dots that were repeated, which is a trajectory. So we looked how much those dots of the MADRS, getting hopefully lower with time, were able to be gathered in clouds of trajectories that would depict 1, 2, 3, 4, 5, 6 subgroups of patients for which you would have a kind of tendency of very good response very early or late and so on. Clusters of trajectories. We had, in fact, 2 clusters in the first one, and as we could replicate it independently in another one, we replicated that 2 clusters are probably describing most efficiently our samples. So this is our 2 clusters. As you see there, the one which is the pink one is not a very good one. You have a little bit of decrease of the MADRS initially, a bit slow, and then you have a progressive improvement, good news, but relatively slow and not getting to full remission. This describes 60% of our patients. And now have a look about 4 out of 10 of our patients. They have a strong and quick response, as you see in the gray curve, getting down very quickly. In fact, being distinguished as early as day 5, there's no overlap because the colors are for the 95% confidence interval. And they go very quickly to full remission and keep in full remission. We tried to look if this observed in my department was also observed in the other one, and we had a very beautiful replication. Not exactly the same percentage, but very, very close. So it looks like it really depicts the usual way patients will react facing esketamine. For your own patient, they will be in class 1 or class 2 because they really depict nearly all patients. But we don't treat patients for only 4 weeks. As you know, it's twice a week, 2 sprays for the first 4 weeks, and then you can decrease the frequency and the dosage according to, well, you manage. So that's what we do, and we've been looking now at about 3 months. And when you look at 3 months, which is the best way to look about the global efficacy of the product, then we observed even striking difference where the 2 curves get different very quickly. That was interesting because we wanted to know how are we able to depict who are the ones that are going to be good responders. The first point which was significant was the number of episodes. More depressive episodes, less treatment response. This is observed everywhere for any kind of treatment. And esketamine, just the same. So that's another information for me, which means don't wait for episode number 19 to prescribe esketamine. Too late. Your chances are being lost with time. So don't prescribe it immediately. You need to have 2 times. It's an expensive treatment for TRD, so it's not for everyone. But for those TRD, the less time you lose, the higher chance you have to get efficacy. I mean, that's probably observed in this case. The second point, which is very important for us, and that's my own feeling, is that never prescribe benzodiazepine. Don't prescribe, don't forget that benzodiazepine are decreasing, they are inhibitors. And don't forget also that the aspartate is blocking glutamate, GABA to release aspartate. So GABA is in fact really needed in order to be creating the loop that shows efficacy. So benzo probably diminished this efficacy. And our result was very largely observed, 20% versus 50%. And that's a very easy one. You just prescribe another anxiolytic if it's being proposed. And it's not the first study. Now we have more and more obvious finding that do not prescribe benzodiazepine with esketamine. Doing that, you will really facilitate a good efficacy. The last point with this study, and I will finish with this specific study, is that the main point is, okay, we should prescribe it as early as possible and avoid benzo. But what is the profile for which patients are going to be good responders? We didn't have very obvious findings for that. So we looked at it in another way. When do we have sufficient information to know if it's worth continuing this expensive product? And we have good news for that. 2 treatments is enough to predict good treatment response with a positive predictive value of 91%. And that was replicated in the other sample, which means that delivering treatment for the 3rd time, you do the MADRS before delivering the treatment. And so they only had it twice. And the capacity to predict those that are going to be in this positive trajectory is 91%. So huge amounts of good signs. I would like to add something more personal. When you have that, please share it with your patient. We never give good news to our patients, but we should build on, okay, you had this side effect, you don't like it, you have to come to our department twice a week. I know it's a little bit boring, but I have excellent news for that. You had only, 15 points being decreased, and you still have a lot of remaining symptoms of depression. But you've been treating for only a week, so it might not be a surprise. And the point is, as you decrease lower than 10 points, it means now you have 91% chances out of 100 to be on the safe side with complete, good, full remission. And that also creates more adherence, more hope for the patient, and good connection with our fight. It is a bit less sensitive, which means that we do also have some late responders because the negative predictive value is not so high, but for the positive predictive value, it's really impressive. So my personal advice would be, do it as most as you can, and explain it to the patient. I'm going to take 3 treatments for 3 days, 10 days altogether. I will push for it, and then we will get a conclusion to see if it's worth or not. And as soon as you have this, don't stop it, because you're really on the safe side. If it's not, then you have to rediscuss it for the patient, of course. So as we said, it is difficult to know which are the good profile. This other study was find a little bit more predictive styles, but they used machine learning, which is a different technique, because crude statistics didn't show it, but it looks like anhedonia, anxious distress, which is mixed symptoms, and bipolarity predicted good treatment response. So for those clinical symptoms, there might be good indicators that the patients are going to be good responders. So these are the studies that have been shown in the file of the dossier. The first one on a fixed dose was having a good efficacy but below statistical significance. And the second one was then with flexible dosage, and this time had a significant difference. It is interesting because for us, we have to maintain this idea that flexibility is a core aspect of a good efficacy of esketamine. And believe me, we have now a lot of patients that are being followed with more or less esketamine. It's a nightmare because we are always, we try to escape. We try to have a larger interval between the treatments, reduce the dosage, but patient maybe sometimes feels a little bit less that, and we re-increase and then we reduce. So this kind of flexibility, which is a real clinical duty, is really part of the program. What was really nice in the study is that you gain 4 times more points with SPRAVATO compared to the comparator. And the other point was that this benefit after a month is observed immediately. So that's the beauty of this mechanism of action. And don't forget one thing. It's nice that the patient has a huge relief, but the adherence issue we have with all antidepressive treatments, I see none of it with esketamine. First of all, because they come, and if they don't come, we phone them back. So usually we know how to catch them. But the second point is, when you have an immediate reward of taking the treatment, then the compliance is fantastic, because they associate the treatments with an immediate effect for which the relief is just hours later, not 2 weeks later. And that makes a huge difference for compliance. The level in the file of responders was 3 out of 4, and remitters was 60%. When you look at the maintenance of the treatments, there is no doubt that if you continue the dosage which was appropriate for the patients, you will even continue reducing the severity of symptoms moderately, because the huge benefit is obtained very quickly in this period. When you compare it with when you add it, of course, to oral antidepressant treatments, it is, of course, needed because we systematically add esketamine to a new antidepressant treatment, if possible, not the one that were previously shown to be ineffective, so a different mechanism of action if possible. And then this association reduced by 70% the risk of relapse, because you continue it, and reduce the risk of even in stable remitters or in the other ones, you still have large benefit. Okay, so another issue which is very important in practice is, what about treatment side effects? First point, are there significant side effects? Yes, plenty of. Let's be very clear about that. Patients complain about it. It's a new treatment with a new effect, and as the effect is immediate, then side effects are immediate too. But there's 2 aspects which is good news. The first one is these side effects are very easy to manage. As you know, we have to monitor the patients for 2.5 hours, at least in France, and so they cannot go out without any kind of remaining side effects. So we monitor them, and after 2.5 hours, we only had 3 patients with hypertension that we had to keep out of 120, so it's very rare. The second very good news is that there is no side effects between your sprays. So that means side effects are acute for usually half an hour, the first half an hour, but afterwards, for the 5 days to come, you have no drug in your blood, so no side effect. So it's only acute side effects. So it's a completely different scheme compared to usual SSRIs. So they usually resolve, they got good tolerability, and the long-term, so no long-term damage, which is definitely needed. I will talk about later about side effects because this is important. This is how we do it. 4 weeks, twice a week, 2 sprays, in order to see how much patients do have a good reaction. And as I just said before, after the second arrows, before arrow number 3, you're going to have very good capacity to know if the patient is going to be good response or not. Then you absolutely need a maintenance phase for another month, and that's usually once weekly. And you can begin modifying the dosage because sometimes patients don't need it as high as initially, especially when the side effects were too high. And then you manage on your own, which is crazy because all patients are being different. But the most important point is if patient had full response and sometimes full remission, then of course it's relatively easy. But for the rest, it really depends on a lot of factors. This is the room where we treat our patients in my department. It was one of the nicest ones because we have a nice view on the garden around our hospital in Sainte-Anne Hospital. If you've not been to Paris, please go and visit my hospital. It's a beautiful one, 15th century, and we have woods all around the hospital. So this one, I chose it because it was so nice, surrounded by trees. But the nurse told me, Philippe, that's a very bad idea because it's too much stimulation and patients felt oppressed by all these woods and views and stimulation because people were passing around at hospital. So we had to close the curtains, which was very sad. So it's a little bit dark, but patients need a very quiet room. It doesn't need to be a huge one. We have in our room 7 beds because we have now so many patients, we need a large turnover. But we also isolate those patients. If not, they don't like it. So they really have to be comfortable and cool. Don't go to your patient. That's a mistake we did initially also. Asking every 10 minutes about how do you feel, how do you feel? And they say, please leave me alone. That's a little bit anxiety because of the depersonalization, deoralization that you observe initially, and patients need to be cool. Now also, that's a new thing we learned. We ask for patients to come with their own headset and have their own visits, their own music. It's much more sympathetic for them, and they tolerate a little bit of anxiety, which is nearly systematically observed when they have this kind of dissociation features. So it's a good point. And they can decide and see what works for them. But it's nice that they do that on their own, without being on their shoulders, because they need a little bit of privacy. As you can see also, we had these devices to check out the hypertension. I don't like this because I'm a psychiatrist, I'm not a cardiologist, but these machines are doing their job very well, and the point is that we rarely use hypertension treatment. So you need just to be very safe about your nose. Blow your nose before taking the treatment. If you have a flu, it doesn't really matter, but you have really to blow your nose before in order to work. No drinks if possible. I would add something also, a trick, because we had it before. On the shim, it looks like the patient has the head very on the backward. But the point is, you shouldn't be this way. It's better to do that a little bit more straight, because if you do that too much, then it goes down your throat, and it's an anesthetic drug, so they hate it. It has a bad taste, and it's not good. So patients have to feel it, but they need to be able to relax. So that's the idea we're laying down on your back. But when you put the spray, be careful not to lay down, because that would be a damage. But now we don't do that anymore. So they could be able to rest. The point is, people sleeping after esketamine is very frequent. And it's probably the best way to cope. So you should facilitate this aspect because it raises a little bit of anxiety. You know, you feel odd, you feel strange. That's a word all patients are using. Sometimes they have real depersonalization. They see their body and say, oh my God, that's really strange. So some of them, they accept it, especially 2 days afterwards. Say, wow, what a relief. I feel so much better now. And then they can tolerate whatever side effect. But if they are really anxious about that, and because of the sedation, if they have a little nap, it's perfect. After that, they will feel completely clean. You have to monitor at the end all side effects and, of course, check the hypertension. So yes, adverse events are being present. I would say systematically. I mean, if there's absolutely no sign, it's a little bit strange. So it's not needed to have the efficacy, but it's a symptom that it really gets to the brain. So dissociation is mild and transient, and it resolves quickly. My own feeling, I would say, is it should be around 100% of patients. A little bit of dissociation is probably the way, all this sprouting and connections between brain areas that I'm ready for that. It gives a lot of information that are known, well organized, and that is dissociation. Somnolence is mild and transient. As I said, relatively very frequent, but that is completely resolved after an hour and a half. So really, there's absolutely no worries about that. The blood pressure, we were extremely stressed by that because we have no cardiologists and we have no GPs and we are not good treating any kind of cardiologic problems in our department. But the point is it's really very easy. I mean, usually they gain 1 or 2 points. So for those having already a high hypertension, not controlled, we just say that we should delay it. But usually, really we had only 3 patients for which we had to prescribe a drug, and 2 hours afterwards it was finished. So the consensus is lacking on how to treat it, and SPRAVATO now is a good alternative. Okay, but how do you compare it to the other ones? That's a very important point because we want to have a comparator, which is not the case when you need a file for EMDA or FDA. So we have this beautiful study compared to quetiapine. Quetiapine was pushed for by the agency because this is one of the largest antipsychotic being prescribed in TRD, and because also, as esketamine, it has proper antidepressive efficacy, and because of the antipsychotic, also pushing for TRD. So it had both aspects being present, and there's no other ones. So that was the decision of the agency to say, look for quetiapine as the comparator. Acute phase for 8 weeks, and then you maintain it for 24 to have a look about the long-term or middle-term effect, and have a good look about efficacy. Of course, all those effects, patients were treated by antidepressant treatments being resistant, it is TRD, and then switched to another antidepressant treatment associated with either esketamine or quetiapine. That's quetiapine number 3 being prescribed. Venlafaxine and mirtazapine could be interesting, but they have no specific design on TRD, and not specifically as augmentation therapy, so that was not a good comparator according to the agency. The ESCAPE TRD study showed that they've been looking at level of remission, that was the point initially, and quickly, that's the idea. But the agency once again said not 4 weeks, because for quetiapine it wouldn't be fair, so they asked for 2 months. And then they looked at relapse-free for the following up, because if patients all get better, but all relapse, you lose all the benefits. The symptoms, there was depression, quality of life, and functionality, which are now the 3 core aspects of depression in every type of study. And they used the MADRS and the CGI. So, esketamine is more efficient than quetiapine. This is the case here for the first 2 months, where you have 74% increase of good treatment response. It means I'm afraid I'm a little bit late, as usual. But this is so nice because for once we can really have information. That's another type of slide I show to patients. When you say, well, I suppose you should use that or instead of that, I rely on my own experience and have a lot of experience with patients being treated for depression. And patients say usually, yes, doctor, okay, doctor, but they don't really care. If you show that and say, what would you prescribe, quetiapine or esketamine? Then the patient asks some details. Tell me, what is it 1.74? What does that mean about? What are the side effects? And the patient is committed, involved, and then the compliance is much better and the results are usually much better. It's just the case also for the longer-term effect after 32 weeks. For those patients being improved, they continue to be improved more frequently than compared to quetiapine. This is the scheme, I think, which is the most interesting one. As you see, after all this 30 weeks period, esketamine is much better compared to quetiapine. But as usual with esketamine, if you look at where does this benefit comes from, it is immediate. You have it directly. And that's a core aspect as a message to patients. Yes, you've been depressed for 7 months, but we do have evidence now you could be improved in 10 days with treatment response. And even now, we can add more than the other one that is currently used for TRD. So we have a lot of good news to patients, which is probably the most important information. That's the case also not for response, but for remission. As you know, remission takes a little bit more time, so it's not 4 weeks, it's 8 weeks. And the benefit on functional remission, which is getting to a level of poor functionality above thresholds of normality, then it's 88% higher with esketamine, which is also good news. And you can keep on your remission, your functional remission on the middle term of this study, which is clear. When you look at the different type of functionality, either you're not going at work, presenteeism, which means I'm going to work, but I have poor efficacy at work, or your productivity loss or activity impairment beyond your job activity, all of them are better with esketamine. The adverse events were studied also. They are completely different, so it's not really interesting to compare because they are not the same kinetic, same organization. But altogether, the main point for patients is, should I keep it because side effects are being tolerable or not? And as you see here, esketamine has a better tolerance because 95% of the time they have no side effects. And as you know, with quetiapine, you have a little bit of sedation because of the histaminergic profile, and the patients stop treatments because of side effects, much more with quetiapine compared to esketamine. So to conclude, a unique strategy up to now, but very quick treatment response in severe populations, which is TRD, with large, obvious, and quick evidence of benefits. Problems now, it's not proposed everywhere for good reasons, very expensive. And for those that have a center not too far, usually the waiting list is huge. In my department, you need 3 months before getting there, but these 3 months are lost for chances of treatment success. You do have some side effects, so they have to be completely clear and explained to patients. And there's plenty of unknown, especially we would love to shift now to what happens between month 3 and month 9, for which we have nearly no information. So it's more about clinical experience. And many data to come for long-term management, detection of the most appropriate profiles and biomarkers. So as I'm a little bit late, may I take the time to take 2 vignettes, or you think it's a little bit, Mr. President, Chairman? May I take 3 minutes for vignettes, or, okay? Sorry for that, I'm always talkative, I love this topic. That's one of my patients, a female, 47, she's working and active. It's episode number 3, so she started around 32, 33. But this time she was depressed for 8 months, a relatively long time. When she arrived in our department, which is specific for TRD, she had 4 different treatments. So a good psychiatrist, very active, never saying that there's nothing I can do. They're really trying. 2 different SSRI, 1 SNRI, and the last one, which was venlafaxine, was associated then with quetiapine for the last 4 weeks. And really, really very, very poor results, a lot of side effects and so on. So the patient here arrived with 27, so middle type of Madras, because a little bit less anxiety thanks to quetiapine and so. So we had to shift to another antidepressive treatment. And as you can see here, woof, a huge reduction of the Madras with 56 milligrams initially. But then we had the problem, because that's a relatively first vignette we had, with the COVID where we had to shut down a lot of our departments. We kept the one for esketamine, but not initially. We had to close it for 1 month. And then we had a relapse. We had to retake it and change the dosage, and then the patient continued afterwards with a decay. I show this example because this is something that is relatively frequently observed. The reported side effect that she had was dizziness. It was only during the treatment. Nausea, which is also relatively frequent. And the few cases for which they say, I don't want it anymore, is much more about nausea rather than for dissociative symptoms, and dysarthria initially, which is not really problematic. These are also two consecutive patients of our cohort, and as you see, the MADRS are real, so that's why they are up and down, because it depends also of the clinician. And so some patients have a very important one, but I like also just to depict those for which you have this kind of huge improvement from one to the other one, 20 points being lost in a couple of days. If you have that, that's very, very good sign. You can move the depressive disorder. It's not crystallized. It can really not frozen. You can move it. When you have this kind of improvement, which is slow and relatively unstable, it's a little bit less good sign because it means it's more difficult and it takes a longer time. I won't get into much detail because it's a little bit too long. Thank you very much for your attention.
Thank you, Professor Gorwood. It was fantastic, and especially the one problem that we have all is to predict who is going to respond and who is not going to respond. And you described very nice new data, which is, I believe, very important. But I'm sure also there are some questions from the audience. Yeah, there.
Thank you, Professor Gorwood. You told us that bipolarity shows a favorable response to esketamine. What is your take on this? Because normally I would expect the other way around.
Okay, so two information. The first one, and I'm sure that Janssen is listening carefully, bipolar depressive disorder is not in the scope and indication of esketamine. So we cannot promote bipolar disorder in TRD. Am I okay with that? Second point, yes. It really does work. It was for us a significant predictive of positive response, and it was the case also with this machine learning information. But may I repeat it? No. It's not the indication of esketamine.
Thank you, Professor, your presentation. Is there any research or do you have any experiments using esketamine in child and adolescent? What do you think about using in children and adolescent? Thank you.
So I think that esketamine is not an indication of TRD in child, so it's not possible to do that. And I personally have no experience at all on children. I'm only treating adults. Sorry for that.
Başka sorular da alacağız ama tabii endüstri destekli bir sempozyum olduğu için indikasyon.
Well, we cannot give you off-label information because this is an industry supported symposium, but of course you can ask Professor Gorwood privately.
I'd like to ask whether this treatment is available for agitated and psychotic depressed patients. Do you have experience with them?
Very good. Thank you for the point. Yes, for agitation, it is possible, but do not prescribe it as directly like that. The patient has to be first not too anxious and not too agitated. As I said, we now systematically avoid benzo. So we use other antihistaminergic drug to calm down the patient. Clearly, if not, it would be dangerous because it creates anxiety. If your level of anxiety is too high, then it's really a problem. Second point for psychotic, no, we never do that. For good reasons. We know that esketamine, being antagonist at MDA, risks to create and facilitate hallucinations. And so for patients already with psychosis, it means we don't. And exactly as we do with other treatments, we first prescribe antipsychotics, and as the patient has no more remaining symptoms, then you are able to do that.
Ben Diyarbakır'dan Doktor Mahmut.
In our clinic, we're using ketamine infusion. Esketamine, unfortunately, is not reimbursed. That's why we're using ketamine infusions. So what are the differences in between? I mean, why should we use esketamine instead of ketamine? Because esketamine is more expensive, and the indications you mentioned. So this is like a step before ECT. That's how I perceive it in our treatment algorithm. What do you think about that?
So for a very important point, which is the point also in my department, we have both. We have ketamine IV and we have esketamine, so we decide systematically. So there's many explanations for that, but we prescribe 3 times more esketamine than ketamine. Ketamine, you have to put an IV, which means that the patient has to be in a bed. For us, patient has to be hospitalized. It cannot be done as outpatients. Esketamine is outpatient. So, treating a patient with a treatment which is needed because of its efficacy for a long term, at least 2, 3, or 4 months, usually not compatible with a long-term hospitalization. So maybe once we will try to begin with the ketamine IV and then get to esketamine, but that's not possible yet because there's no studies for that. The second point is ketamine is relatively dangerous. I mean, don't miss the dosage because you can make the patient sleep and then not breathe. So it has to be monitored with a medical surrounding, which is not the case with esketamine. Esketamine, what we need is a nurse, nothing else. We do have interactions with a clinician because we do the MADRS systematically, but now we do that with a social worker, not a psychiatrist. So it's extremely simple to use. Ketamine IV, we use it for melancholia, exactly as you said, before ECT usually, because it's much cheaper and much easier and quicker. But usually they are for inpatients because of the severity, the need of monitoring, and all the setting of the treatment care, which is not exactly the same. So yes, esketamine doesn't mean ketamine has no room. We use it, but it's so much simpler and especially so much compatible with getting back to life. Because as soon as your patient is out, usually we stop ketamine IV and then patients have a relapse. For that, they can continue esketamine in daycare center. So it's much more compatible. And as I said, we have both, and we use esketamine 3 times more than ketamine IV.
Thank you so much. I would like to ask you about this cluster analysis that was done, and I'm particularly interested in the treatment response prediction. I was asking myself, and it's really nice this being replicated, but I was asking myself if there's a chance of having a placebo included in there to see if maybe this pattern happens also similarly.
Yeah, thank you for the point, because, placebo effect is a nightmare. Usually, all the placebo effect we had occurred after 2 or 3 weeks, but as soon as you propose a treatment with 24 hours, you have a placebo after 24 hours. Patients are very clever, and it's not because of patients, also our way, because we are the one usually making the ratings for that. Yes, definitely, placebo effect is included in both aspects. My feeling is that these are TRD-resistant severe chronic disorder usually, so the placebo effect might be relatively weak. But the point is that's not true, because if you look at, compared to placebo, the Transform 1 and 2 studies had a high placebo effect. So yes, it's part of it. But the point is, in everyday life, we don't really care, because placebo or compound linked, the only point I want is to get my patients better. So even if there is included a part of placebo, well, I will manage with that.
Do we have any other? Yeah, there's Professor Çağdaş.
Thank you for your presentation. It was encouraging. I've got fair enough experience with both IV ketamine and esketamine, and in super treatment-resistant patients, they tried everything, and they're chronic patients. And what I see is both with esketamine and ketamine, although they feel depressed with the infusion or with the application of esketamine, their functionality increases, and also their mobility and self-hygiene increases. But they feel depressed. Their mobility increases, but they feel depressed. And I cannot say that it's motivation increase, but I feel that it's motivational increase. With IV ketamine, if we increase the dose to 1 milligram per kilogram, we can have a greater response. But for esketamine, we don't have that option because the dosage is fixed. Do you have any advice on the patients who are responding but not remitted? I mean, they feel depressed, but their mobility increases and self-hygiene also increases.
Sure. So thank you for very precise points and definitely important ones. So we do not have flexibility initially, but we have a lot of flexibility after the 4 first weeks. You know, we can go from 28 to 56 milligrams and even 84. And we do that a lot. We use a lot of flexibility. Don't forget also is that it's not 100% of response. So some patients are being not responders to esketamine. And the best thing to do then is to stop it, because there's no miracle. If it's not a good responder, we should stop and try another one. My experience is that usually after esketamine, we have ECT, which is usually bad news for patients. For us, it's 6 weeks of hospitalization, and the patient and the family don't like it. To get to the other point about how we manage this organization of care for the settings, it's really a difference between patients failing on esketamine on daycare center, 2 hours and a half twice a week, getting to full-time hospitalization. And that's for patients usually very, very bad news. So that's why also we push a lot for flexibility. But after 1 or 2 failures, even if we have twice a week with 3 sniffs systematically and no improvement, we stop it. Because of course, we know that there are important frequency of non-response. There's one thing I would like to add, I don't know if it's your own experience also, is that as esketamine is supposed to boost the effect of the associated antidepressant, you shouldn't forget that, and that's now our experience, that for some of these new antidepressant treatments, they have no efficacy. So you have the esketamine benefit. Patient gets much better after 4 weeks. And we have now around 30 cases that had relapses afterwards. Because as soon as you decrease the level of esketamine, and if we re-increase esketamine, then the patients get better. And now what we do, instead of boosting again esketamine, we shift the treatment that was associated to another one. And we have now 10 patients that got much better because probably of this. And that's the problem with the association. You don't know if it's A, B, or A cross B. So this is a point that we have to manage. Thank you.
Yeah, there is one last question. Öndeyiz burada.
Ben Ali Safet hocama sormak istiyorum ama ayıp
I have a question to Professor Ali Safet. Professor, we have people using ketamine IV, so this should not be misunderstood. So do you know this? Because a psychiatrist is, convicted or arrested because he was using ketamine on adolescent patients. Psychiatrists, can they use ketamine IV on their patients? Well, we're experienced in our clinic. We're using it on our patients. And Çağdaş asked a related question. He is responsible for our affective disorder. Çağdaş, would you like to answer the question? A psychiatrist cannot use ketamine IV. We use it with an anesthesiologist, and the anesthesiologists do not let us use that. It's 0.5 milligrams to 1 milligrams per kilogram, and we have to get the consent. And that psychiatrist He was arrested not because of ketamine use, but because of abuse allegations. But it is also indicated in Europe for a TRD. So it's not a trial drug. Actually, ketamine is indicated for TRD. That's abuse. That's abuse. You're right. I asked this question so that everybody should hear this. An anesthesiologist should be in the room to use ketamine ID. Of course, that's what I meant. I mean, we're not using it ourselves. We do it, we infuse it with an anesthesiologist in a room where we also use the ECT. We take all the necessary precautions, and we have an anesthesiologist present from start to finish. So we have never had any problems.
Physicist in
Yes,
France
yeah.
also.
Yeah, maybe I wasn't clear. But definitely, that's what I meant with the patients being hospitalized. It's a surrounding. We have a huge department for ECT and ketamine. And so they are taking care completely of this. And that's why it's a little bit more complex with the ketamine, because it needs a medical surrounding.
Evet, Roberto'dan son soruyu alalım ve
I'm sorry, just one question that occurred to me. So some of the patients before, when they are treated with intravenous ketamine, there was some concern of the level and becoming dependent on it. Do you have any information about this in the context of Spravato?
Yes, I have, first of all, my own experience, 0. But the point, it's probably not the best context to assess that, because they don't decide anything. We give the devices, and there's no control. In our hospital, the esketamine is being, watched like a bank, Swiss bank. We have specific buildings for that, and it has to be checked everywhere. But the risk to abuse esketamine is close to 0, because having a real shoot of ketamine with esketamine, we need 30 devices, which means 10 boxes, and it's nearly not possible. And I think that they may also go to using it as outpatients independently. So I guess that the risk of abuse with this device is really, really close to 0.
evet, herkese katılım için teşekkür ederim.
Okay, thank you very much, everyone.